Let's talk about very important points about pulmonary embolism and DVT, that is deep venous thrombosis. So risk factors for pulmonary embolism and DVT: age. As age becomes greater than 50 years, it becomes significant and increases with each year of age until the age of 80 years. Obesity is important risk factor, especially BMI greater than 35. Pregnancy and postpartum state is an important risk factor. Prior history of venous thromboembolism. Solid cancers risk greatest with adenocarcinomas and metastatic disease. A history of remote inactive cancer probably does not increase the risk. Hematologic cancers, so acute leukemia, myeloma, confer the greatest risk, particularly when treated with L-asparginase and thalidomide derivatives. Thrombophilias, right, and recent surgery or major trauma are increase the risk factors. Other risk factors are acute limb immobility of two contiguous joint confers the highest risk. Bed rest, approximately more than 72 hours. Indwelling catheters cause approximately one half of the deep venous thrombosis. Long distance travel, smoking, congestive heart failure, previous history of stroke, or risk is greatest in the first month after deficit. Estrogen, people who are on hormone replacement therapy or oral contraceptive pills. Non-infectious inflammatory disorders increases the risk of pulmonary embolism and DVT. Classification of pulmonary embolism and DVT. Massive pulmonary embolism accounts for 5 to 10% and it is characterized by extensive thrombosis affecting at least 50% of the pulmonary vasculature. Dyspnea, syncope, hypotension, and cyanosis are hallmarks of massive pulmonary embolism. Submassive pulmonary embolism accounts for 20 to 25% and is characterized by right ventricular dysfunction despite normal systemic arterial pressure. Combination of right heart failure and release of cardiac biomarkers indicates a high risk of clinical deterioration. Low risk pulmonary embolism contributes to 65-75% of the cases. These patients have an excellent prognosis. The symptoms of pulmonary embolism are breathlessness, unexplained by auscultatory findings, ECG changes, or clear alternative diagnosis on chest radiograph. Chest pain with pleuritic features is the second most symptom of pulmonary embolism. The classical pulmonary embolism pain is in the thorax between the clavicles and costal margin that increase with cough or breathing. Pulmonary embolism symptoms range from none to sudden death. So Homan sign is pain in the posterior calf or knee with forced dorsiflexion of the foot. Moses sign is gentle squeezing of the lower part of the calf from side to side, causes pain. Nehoff sign is thickening and deep tenderness elicited while palpating deep in calf muscles. Linton sign, after applying tourniquet at saphenofemoral junction, patient is made to walk. The limb is elevated in supine position. Prominent superficial veins will be observed. Deep venous thrombosis or DVT. Lower extremity DVT usually begins in the calf and propagates proximally to the popliteal vein, femoral vein, and the iliac veins. A difference of greater than 2 cm between right and left leg diameter at 10 cm below the tibial tubercle doubles the likelihood of DVT. Lower limb DVT is about 10 times more common than the upper limb DVT. Proximal DVT that causes complete venous obstruction leads to increased compartmental pressures manifested as extremely painful swollen in extremity. Phlegmasia alba dolens and Phlegmasia cerulea dolens. So well score for DVT. The points are given accordingly. So more than 3 points high risk, 1 to 2 points is moderate risk and less than 1 point is low risk. So active cancer or treatment within 6 months or palliation, 1 point. Paralysis, paresis or immobilization of lower extremities, 1 point. Bedridden for greater than 3 days because of surgery within 12 weeks is 1 point. Localized tenderness along distribution of deep veins is 1 point. Entire leg swollen is 1 point. Unilateral calf swelling of greater than 10 cm below tibial tuberosity is 1 point. Unilateral pitting edema, collateral superficial veins. Alternative diagnosis as likely as or more likely than deep venous thrombosis is -2. Right? Prior history of DVT or pulmonary embolism is 1 point. Now coming to the well score for pulmonary embolism, if there is suspected DVT, there is 3 points. Alternative diagnosis less likely than pulmonary embolism, then this is 3 points. Heart rate greater than 100 is 1.5. Prior venous thromboembolism 1.5. Immobilization within prior 4 weeks is 1.5. Active malignancy is 1 and hemoptysis is 1. So pulmonary greater than 6 points is high risk, 2 to 6 is moderate risk, and less than 2 is low risk. So this is one more important chart that is known as the T score to determine the risk of major bleeding during anticoagulant therapy. Right? If recent major bleeding, if it's yes, then it is +2. Creatinine more than 1.2 plus 1.5. Anemia more than 1.5. Malignancy history +1. Pulmonary embolism clinically overt PE is +1. Age more than 75 years +1. If the points are 0, then it is low risk. Low risk. 1 to 4 is indeterminate and 4 is greater than high risk. This score is used to determine the risk of major bleeding during anticoagulant therapy.